Hello everyone, I am Dr. Subha, Associate Professor, Department of Ophthalmology from Sree Balaji Medical College and Hospital. Today I will be discussing about primary open-angle glaucoma. Primary open-angle glaucoma is also called the silent thief of vision. To catch a thief early, we need to know some characteristics of him. So today we'll be learning about the definition, risk factors, clinical features and the diagnostic evaluation of glaucoma so that we detect it early. Glaucoma is defined as a syndrome or a group of disorders of progressive optic neuropathy with characteristic optic disc appearance and specific irreversible visual field changes with or without an increase in the intraocular pressure. It is the third leading cause of blindness throughout the world and also the major cause of irreversible visual loss. There are various ways to classify glaucoma. But the main classification is into open angle and closed angle. By angle, we mean the anterior chamber angle which is present between the cornea and the iris circumferentially. And gonioscopy is a test to visualize whether the angle is open or closed. Again, glaucoma can be classified into primary and secondary. In primary, there is no discernible ocular or systemic cause for the increase in the intraocular pressure. Whereas in secondary, there can be ocular causes like pigment dispersion syndrome or uveitis and systemic factors like steroid intake or metabolic disorders which increase the resistance to aqueous outflow and hence results in increased intraocular pressure. The exact etiology of POAG is unknown. But there are certain predisposing factors like increasing age, black ethnic race, and a family history of POAG. The inheritance of POAG is polygenic, but the most common genes implicated are myosin and optineurin. Other risk factors like increased intraocular pressure, having nearsightedness or myopia, and diabetes, and history of chronic smoking are also responsible. So what is the mechanism by which POAG occurs? Though gonioscopically the angle visualized is normal, there can be microscopic structural damage which leads to functional damage. Reduced aqueous outflow occurs through the following mechanisms. The trabecular meshwork can be thickened and sclerosed, causing narrowing of intratrabecular spaces. There can be deposition of amorphous material in the juxtacanalicular space, leading to collapse of the Schlemm's canal. Immunogenic mechanisms are also implicated with deposition of antigen-antibody complexes in the trabecular meshwork. So this diagram shows us that the pathway from the production of aqueous humor, namely the ciliary body, till the angle is anatomically normal. But the trabecular meshwork is clogged, which results in increased intraocular pressure, and hence it directly causes damage to the optic nerve. POAG is usually asymptomatic in the early stages and hence it is notoriously called the silent thief of vision. But significant visual loss occurs in the late stages along with field defects. In the end stage, the patient is left only with a tunnel vision and which progresses to complete blindness. The diagnosis of POAG is made with certain investigations. Intraocular pressure recorded should be greater than 21 millimeters of mercury on more than one occasion and diurnal variation greater than 8 millimeters of mercury by tonometry. The standard tonometry is Goldman applanation tonometry. And gonioscopy is done to confirm if the anterior chamber angle is open. Fundus examination is done to look for specific glaucomatous optic disc changes. Perimetry is done to document characteristic visual field defects. Since the patient will be asymptomatic in the initial stages, they seldom come to the OP for glaucoma screening. Hence, it is wiser to do an opportunistic screening, meaning screen for glaucoma when the patient reports for some other symptom to the ophthalmology OPD or to the community health setup. So, let's discuss what a normal optic disc looks like. We all know there is nothing normal in medical field. There are always variations and deviations from normal. So we can use the term typical. And a typical optic disc has the following features. A vertical disc diameter with an average of 1.7 to 1.8 millimeter, a slightly vertically oval disc and a horizontally oval cup. The neuroretinal rim follows the ISNT rule, in which the inferior neuroretinal rim is the thickest, followed by superior, nasal and then the temporal. The NRR is usually yellowish orange or pinkish yellow in color. The optic disc looks almost similar in both the eyes. The central retinal vessels emerge slightly nasal to the center, and the retinal nerve fiber layer reflex is visible brightly superior and inferior to the disc. In POAG, the optic disc acquires certain characteristic changes which help us in diagnosis. The early changes which occur on the optic disc in POAG are a vertically oval cup, asymmetry of cups between the two eyes with a difference of CD ratio greater than 0.2, focal thinning of neuroretinal rim, retinal nerve fiber layer defects, and splinter hemorrhages. A point to be noted that ISNT rule is no longer applicable in the diagnosis of glaucoma. In advanced stages, the optic disc changes become very obvious so that it is easier to diagnose POAG. The NRR thinning is very profound and there is marked cupping with a cup disc ratio greater than 0.7 to 0.9. There is nasal shifting of blood vessels. Bionetting sign is seen, which is double angulation of the blood vessels at the edge of the disc. There is bearing of circumlinear blood vessels due to loss of NRR and the blood vessels appear to hang in midair. Laminar dot sign is nothing but slit-like pores of lamina cribrosa becoming visible due to axonal loss. The end stage is optic atrophy, where the entire NRR is destroyed and the optic nerve head appears white and is deeply excavated. It is also called cavernous optic atrophy. There are two theories implicated in the pathophysiology of disc change. One is the mechanical theory, in which increase in intraocular pressure pushes the lamina cribrosa backwards, in turn squeezing the nerve fibers, which leads to disruption of axoplasmic flow. In vascular theory, there is reduced blood flow and deranged autoregulation, which leads to ischemic atrophy and ganglion cell apoptosis. So, the first picture shows a normal optic disc with symmetric cupping in both eyes. The picture above is a color fundus photograph, whereas the picture below is a red-free photograph, which is more useful in evaluating the optic nerve head and the retinal nerve fiber layer because of the good contrast. The second picture shows asymmetry in cupping between two eyes, with the first eye having a 0.7 cupping and the second eye having a normal 0.3 cupping. This picture shows an early sign of POAG, namely vertical enlargement of the cup. The superior and inferior poles of the optic disc are more vulnerable to damage because the glial support for the axons are lesser here compared to the rest of the area. And vertical cupping of the disc is also associated with focal notching because of the loss of the neuroretinal rim in the poles. The first red-free photograph shows a wedge-shaped RNFL defect superior to the disc marked by an arrow. And the second picture shows a splinter hemorrhage in the infratemporal area of the disc. This splinter hemorrhage is more common in normal tension glaucoma and is also called a Drans hemorrhage. So the first picture depicts bionetting, in which due to loss of neuroretinal rim, the blood vessels take an acute bend at the edge of the disc and they acquire a double angulation. This is similar to the bayonet, which is a weapon used in combat warfare, and hence the term bayoneting. Laminar dot sign is depicted in the second picture, in which the pores of the lamina cribrosa through which the axons go through are exposed due to extensive axonal atrophy. This picture shows us the end stage of glaucomatous optic atrophy, in which the cup is pale and excavated and the entire neuroretinal rim is either thin or completely absent. And this resembles the mouth of a bean pot, and hence it is called bean pot cupping. Next, we will be discussing about the visual field defects occurring in glaucoma. The visual field defects of early glaucoma are usually in the periphery and hence goes unnoticed by the patient, since the patient sees binocularly. A scotoma is a non-seeing area in the visual field, and it is usually detected on perimetry. Perimetry is a technique of plotting the patient's visual field. There are basically two types of perimetry: kinetic, in which the target keeps moving, and static, in which the target remains stationary. The field defects enumerated in this slide had originally been described on kinetic perimetry printout, since they have smooth contours. This has largely been replaced by standard automated perimetry, which uses a static target. So let's discuss about the characteristic visual field defects of glaucoma. A paracentral scotoma occurs 5 to 10 degrees from the fixation point. A cedar scotoma is a comma-shaped or sickle-shaped scotoma, either superior or inferior to the blind spot. Arcuate or germ scotoma is more typical of glaucomatous field defects, and it is interesting to note that the field defects in glaucoma respect the horizontal raphe. The field defects initially start in the superior hemifield or the inferior hemifield, and when they progress, the arcuate scotomas, when they coalesce, it results in a double arcuate scotoma or ring scotoma. A nasal step is formed when there is a depression of one hemifield relative to the other. It is also called Ron's nasal step. In the end stage, the patient is left with a central tubular or tunnel vision. The first picture shows us a germ scotoma, which is classic for glaucoma. Germ's area is around 10 to 20 degrees from fixation. In its full form, an arcuate scotoma starts from the blind spot and ends in the nasal horizontal raphe, becoming widest and closest to the fixation point. The next picture shows some characteristic visual field defects of glaucoma as charted on the standard automated perimetry. Another important investigation in the diagnostic evaluation of glaucoma is optical coherence tomography, which gives us a quantitative analysis of the optic nerve head parameters and the retinal nerve fiber layer thickness. It is helpful in evaluating glaucoma when the visual fields are normal but the optic disc appears suspicious for early glaucoma. It is very essential to note that the diagnosis of glaucoma can be made only by correlating the three factors, namely intraocular pressure, the appearance of the optic disc, and also the corresponding visual field changes on perimetry. So the diagnosis of glaucoma requires a good clinical acumen and also a knowledge about the interpretation of the diagnostic results of glaucoma. But it is interesting to note that glaucoma remains the most underdiagnosed and also the overdiagnosed entity in ophthalmology still today. Treatment of POAG, though it is not under the purview of this presentation, I'll just outline the modalities available. The mainstay of POAG is medical management in the form of monotherapy or combination therapy of anti-glaucoma drugs. When the patient is not tolerant of medications, or if the patient is not compliant with the medications, or if the disease progresses in spite of maximum medical therapy or maximum tolerated therapy, there are other options available. Laser can be done in the form of organ laser trabeculoplasty or SLT, selective laser trabeculoplasty. There are various surgeries available and the procedure is chosen according to the needs of the patient, considering the risks and benefits of each procedure. To summarize, primary open-angle glaucoma is the third leading cause of blindness throughout the world and also the major cause of irreversible visual loss worldwide. Hence, it is important to have a sound knowledge about this disease so that we diagnose it early and prevent permanent visual loss. Thank you for hearing and have a nice day.